everyone? Thanks for coming, you guys. I'll try not to be on here forever with you. I just wanted to meet with you again and make sure that everyone feels a little bit better about the test. So, can everyone hear me okay?
Yeah.
Okay, perfect. Okay, so I just wanted to do a couple of things with y'all to see if that helps. So, let's see if I can get to where I need to be. 1 second. All right, let's see if we can do this together. So this has to do with hypothyroidism. This is on the Point website, that goes with the book. So under student, I'm trying to think what the heck that's called. Under student resources, there is a section that something like practice and learn activities. That's what this is. So let's see if we can do this real quick. Okay, so this says Thelma Coffey is 35 years old. She presents to her primary care provider reporting extreme fatigue. Upon further investigation, the nurse identifies that she also had issues with recent thinning of her hair, dry skin, voice changes, menstrual changes, and complaints of being cold all the time. She reports not being under any additional stress at home or at work. The nurse identifies that the patient's complaints are being symptoms of hypothyroidism. So hypothyroidism occurs most often in women who are what ages, guys?
Is it 30 to 60?
Let's try that. Good job, yeah. Okay, the primary care provider completes a physical assessment and orders lab diagnostics to further evaluate Ms. Coffey. Included in the screening are the serum thyroid stimulating hormone level and a serum free T4 level. The nurse knows that the thyroid stimulating hormone controls the release of which thyroid hormones?
A.
Okay, good job. Let's go in here. Okay, results of the lab diagnostics reveal a TSH level of 7.0 and a T4 level of 0.5. The nurse educates the patient that a blank thyroid stimulating hormone level indicates hypothyroidism.
Decreased.
So this one's opposite, it's increased. So what's low with this is your T3 and T4. So with hypothyroidism, then you don't have enough of those hormones, but the stuff that normally helps you secrete those hormones is increased. Okay.
Yeah, sure.
Just use it.
Okay, the nurse knows a blank serum free T4 level indicates hypothyroidism. What did we just say?
Decreased?
Yeah, so remember, it's just opposite with the TSH. So the TSH is doing the opposite thing as the T3 and T4. Okay, the primary care provider orders Ms. Coffey to begin levothyroxine 25 micrograms PO daily. Which statement made by the patient verifies that the nurse's education regarding levothyroxine was effective? If you don't know, just guess. It's okay.
I'm going to guess A.
So this is just a thyroid replacement because you don't have enough of it, so it's making you have enough by giving you this medication. So it's making your levels okay. The nurse will educate the patient to monitor which of the following parameters while taking levothyroxine. Again,
C.
what is it?
I'm guessing C.
C, you said?
Yeah.
So this is going to be pulse rate. When you think of, you know how I was showing you guys those pictures? So think of the guy with the earmuffs on and all of those things around him in that picture. So remember, one of the signs and symptoms of hypothyroidism would be a low heart rate, a low pulse. So that's why we're monitoring this, because if you get too much of a level of this in your system, you can actually go the opposite way and have like a high heart rate and be like hyperthyroid. Okay. Oh, now this doesn't want to go forward. What the heck? Well, I guess we're done with this. I can't get it to work for me now. I think the last slide would have just been a recap of hypothyroidism anyway, so that's okay. All right, so the other stuff I want to do, I just want to review a couple of things that we talked about, you know, like as far as content, and then I have some questions that we'll do together on Kahoot again. All right, so tell me, so let's start with diabetes here. So tell me, how would you figure out that someone has diabetes? How do you diagnose that?
Talking about the A1C, like the hemoglobin test, right? Not the hemoglobin, like the like there's that blood sugar
A1C.
test, like the A1C, yeah.
Well, it's not going to be the A1C to tell you if someone is diabetic or not. Because the A1C, you know, that's just telling you how your blood sugar's been over the past 3 months. So we typically watch that when we think someone's had some high blood sugars, so then we look at that. So how would we diagnose them with diabetes? Think back to our diabetes PowerPoint. We had like a few different tests that we could do.
Would you do a blood glucose test?
Okay, what kind?
Would it be a fasting blood glucose?
Okay, so that's one of them. So if we did a fasting blood glucose, what would we want your glucose to be? What would we want it to be so that you're not diabetic?
70 to, I want to say 120, but I'm not sure. I think the other one's wrong. Like, I know it's 70.
Okay, so 70 is like a good low level there. So if we did a fasting blood glucose, if this person had 126 or higher, that's telling you that they have diabetes. Okay, so fasting glucose. And typically you wouldn't just take one reading. Obviously you'd probably do a couple of tests to decide this. What would another one be that we could do? I think there's like two other kinds of ways you can test blood sugar.
Maybe something to do with like the pancreas. I'm trying to remember. I'm guessing.
Is the oral glucose?
Yes, there's one. Oral glucose tolerance test. That's the one that we typically do when someone's pregnant. You know, after so many weeks, we check to see if they're diabetic at that point. So with that one, it's like 2 hours after you drink that stuff, and that stuff is like really sugary yuck. But anyway, you drink like a big thing of it, and then they test your blood sugar 2 hours later to see where you're at. And to like, I forget what the actual number is, but like say it's 200 is your top cutoff point. So if you were 201 or 202, that's saying you're diabetic. So that's another way. And what's the third way that we're forgetting?
Is it the casual plasma glucose concentration test?
Just like a random glucose test.
Yeah.
So yeah, I think that's what you're trying to say. So a random glucose test, just any time during the day, whether it's, fasting or not, if that is greater than, 150, 200, that's where we're trying to see if you're diabetic or not, right? So fasting glucose, random glucose, oral glucose tolerance test, all three of those are kind of ways that we check to see if someone's diabetic. Now, what are the symptoms that make you think someone's diabetic?
Excessive thirst.
Excessive thirst. What else?
Excessive urination.
Yes. What else?
Excessive hunger.
Yeah. So those 3 P's. So all 3 of those would be going on, and that's just remember we're talking high blood sugar with those. We're not talking low blood sugar. It's high. Now, other things that you might see that might make you think that this is going on with someone, like remember we said if you were type 1 diabetic, sometimes they'll have a low weight. And why would that be? Why would that make us think that they're diabetic?
Doesn't it do something to your metabolism? Not like I don't know what I'm trying to say. When you're like a type 1, don't you get really sick?
You can, yeah.
Like flu-like symptoms, and then
You don't always have flu-like symptoms, but I mean, so if you're type 1 diabetic, say you don't know that you are, when you go into, usually it's a DKA episode, so when you go into that, that's how you figure out that you're diabetic, right? And what happens with DKA? So remember, with DKA, we're having a few things go on. We've got a really high blood glucose, and this is because of what?
Is it because you're in diabetic ketoacidosis, so you're like consuming your own fat instead of sugar?
Yes, that's what I wanted someone to say, yes. So again, going back to what I said a few minutes ago about this weight loss, that's why you would have the weight loss, because you're consuming all this fat because you can't do what you normally would do. Okay? All right, let's see, what else can I ask you here? All right, let's talk about exercise. What does exercise do with our blood sugar?
drops it.
Okay. When should we not exercise? Do you remember that conversation that we had in class about that? So remember we said, yes, on a normal basis, exercising is going to help bring your glucose down. But there's also a time where you shouldn't exercise, and that would be when your sugar is really high. So when it's already high, we said that it could make your sugar go even higher, right? Do you guys remember that?
Okay, so what's the basis behind that?
So just listen to me for 1 second here. So if you exercise when your sugar's already high, like say it's 275 and you go running or something, it increases your secretion of glucagon when you're exercising. So glucagon is going to cause the liver to release more glucose, and as a result, it shoots your blood sugar up even more. The other thing I want you to remember with exercise, so normally, you know, if your blood sugar is at a decent rate, you should always check your blood sugar before you exercise to see where you're at. And if it's okay, then that's a great thing to do because it does help keep your sugars down. But the other thing I want you to remember is that you should always eat some kind of snack before you exercise to prevent unexpected hypoglycemia. Because, you know, like we said, it can make your sugar go down. So if you don't have that snack on board, then it might, you know, really bring it down too much. So we tell people to eat a 15-gram carb snack before they go exercise. Do you guys, let's see. Tell me about sick day rules.
You should monitor your blood sugar every, I feel like it was like 3 to 4 hours.
Okay. What else should they do?
If you can't keep anything down, you should try to drink sports drinks, something that was like sugary, I think.
Okay.
Yeah, it was like fruit juices.
Okay. What else should they do?
You still take your insulin, right?
Definitely. Because that's the biggest mistake that everyone does is they just don't take their insulin, and then it causes them to be even sicker. And then they have to come in with like a DKA episode. So those are the big things. And then the other thing that no one said was, especially if you're type 1 diabetic, they tell you to test your urine for ketones. Okay, so that's all part of sick day rules. Let me think. What's the best way that you could teach like a group of people about how to decrease your risk of getting diabetes? What's the best thing they could do?
Lose weight.
Yes. That's the biggest thing that's going to help you is losing weight, keeping your weight down at a good level. Tell me the difference between type 1 and type 2 diabetes.
Type 1 is juvenile, where they're not producing any insulin, and type 2, they produce not enough insulin.
Okay. So type 1, you don't have enough insulin to do what you need it to do. So typically you are going to be treated with insulin, right? And you're right, sometimes you are, you get type 1 like younger than some other people would. Now, type 2 is going to be, you have insulin resistance. So you have insulin there, but your body just can't utilize it like you would want it to. Does that make sense? So
that does make sense.
Type 1, you don't have enough. It's just not there. Type 2, it's there, but your body just can't utilize it like it should. So you just continue to have high blood sugars. Now, what's some other differences between the two?
One has to be treated with insulin and one can be treated by pills.
Okay. And it doesn't necessarily mean that always a type 2 diabetic is going to be just pills, because they can be on insulin as well. But yeah, you're right. What else?
Before we go any further, I do have, can you clarify something for me? So we said type 1 comes on at juvenile, but is that always true?
Not necessarily. Like a lot of people will get it that way, but not everyone does.
So the age factor, there's not going to be anything on a test that will snuff us like that, right? Okay.
What else is different between the two? So remember, type 2 diabetes is more lifestyle related, right? So it's typically because you're not eating right, you're not exercising enough, all of those types of things. So if you actually changed a lot of those lifestyle things that you do, then actually you help yourself so that you don't end up getting worse and getting into that, right? Now, type 1 is not lifestyle related, right? So when you talk about like, hey, what caused it? There's a lot of conflicting things out there that say, oh, it's a little bit of your environment, it's hereditary, it's autoimmune. There's a lot of different things that people say, but it's that one definitely is not lifestyle related. You can't help having type 1 diabetes. There's nothing you could have done to fix that. But type 2, it's under your control. You can actually, fix that. Tell me what gestational diabetes is.
It's when a woman develops diabetes during pregnancy.
Okay. And what's it similar to?
That is a great question.
It's similar to type 2 diabetes, right? So what's causing this mother to seem like she has diabetes?
The placenta.
The placenta, definitely. So remember we said the placenta, it secretes hormones, and the hormones are what like screws you up and makes you be like diabetic. So the minute this person delivers their baby and they deliver that placenta, the placenta's out, then they're no longer, considered diabetic. Okay, so it's very, significant. It's totally different compared to certain other things. Now, what is that person at risk for later on in life?
Type 2 diabetes.
And how about their children? Type 2 diabetes, right?
Yeah.
So like for me, I had this. So I'm at risk for type 2 diabetes, and so are my boys, because I had it when I had my boys. All right, let me think what else. Okay, tell me the difference between HHNS and DKA.
Isn't HHNS like the highest blood sugar? Like I feel like it was like 600 and above, and then DKA was like 300 and above.
Okay. So
DKA was with type 1, right? And then HHS was with 2.
Okay. Anything else stand out to you that's different between the two? You're right with everything you just said. Let's think causes for a second. So with HHNS, typically the person is sick at first, like, I don't know, say they have, a case of pneumonia or the flu or something like that. Something causes this to set them off, right? So when they get their episode of HHNS, they are going to be really high with their blood sugar. What else is happening along with the high blood sugar? So they are really dehydrated, right? Because we have this big osmotic diuresis that happens. So they're going to have messed up electrolytes. But the difference between this and DKA is we don't go as far with HHNS because we're not digesting our fats. We don't have ketone bodies as a result. So that's one difference there. And then another thing is some of your signs and symptoms, like you're going to look kind of similar to someone with DKA, but not completely. So like the HHNS person will have neuro symptoms. So they'll get confused. They might be super lethargic or have some delirium or something like that going on. That's your neurosymptoms. You won't see that with DKA. Now, with DKA, remember you have that fruity smell to your breath, you have the Kussmaul respirations, you have some significant things like that that are just DKA, right? Did you guys watch that video that I posted with that little kid?
I did. It was really sad.
It is sad, but it's a good video to watch because it really brings it home what that is.
Oh, for sure.
So in that video, if you didn't watch it, make sure you go watch it because it is helpful. It's only a couple minutes long. It's not super long. So in that video, this kid, what was he, Brandon? Was he like 3 or something?
Maybe like 4 or 5. He wasn't very old, and he was just hyperventilating, and he looked unconscious. It was, I don't know, depressing.
Okay, so in the video, this kid, his mother brought him into the ER, and in the video it said that he had some kind of dental abscess. So that's what kicked him off into this episode. So he was diabetic, and she checked his sugar before she put him to bed the night before, and he was like, I don't know, 95 or something. He was normal, you know? So she didn't think anything of it, put him to bed, and then the next morning when she went to get him up, she couldn't wake him up. He was real lethargic, and he was breathing funny. And so this video is about those Kussmaul respirations and what it looks like. So it looks like this person is just really working to breathe, and you know, like they're really having a hard time. But it's not that they're having a bad, you know, oxygen saturation. That's not what this is. So it's real like deep breathing that they're doing, and they breathe fast, but they're not in distress. So like you, which I don't think I have that question on this test, but I've put a question on the test in the past where it talks specifically about this, and it'll say, what should you do for these Kussmaul respirations? And there was an option that said, oh, make sure you put oxygen on them and do all this stuff. Well, yeah, you're going to put oxygen on them just for comfort, but it's not fixing the problem. So the only way you fix that problem and get rid of those Kussmaul respirations is by giving them IV insulin, because you're treating their DKA. You guys see what I'm saying?
Yeah, that makes sense.
All right, let me think what else here. Okay, I think I hit most things in here. There's probably a few things I didn't say, but don't forget to look at your insulin stuff as far as peak and trough, not peak and trough, but peak times and you know, all those other times, you know, for your insulins. You need to know both names of the insulin so you don't get screwed up when you see it on the test. And then you also need to look at your oral diabetes meds too, to make sure you know some, you know, things about them. All right, so then if we go to the endocrine stuff, remember we talked about hypo and hyperthyroidism, right? So we said hypo meant that you weren't producing enough thyroid hormone. And the thyroid hormone that we're talking about is T3 and T4. So you're low in that, so that would mean you're high in TSH. You know, again, hypothyroidism just means that your metabolism is super slow, like things aren't working as good as they should. We said a lot of times there's older adults who have it that get misdiagnosed because they think it's like normal signs of aging, you know. Tell me some causes for hypothyroidism. What's like the number one cause? Sounds like a Japanese name.
Is it Hashimoto?
Yes, Hashimoto's thyroiditis, right? So that's probably the number one cause. You could also have hypothyroidism because you've had your thyroid out, right? So once you get it removed, you're going to be hypothyroid the rest of your life. You know, there's some other reasons there, but just, you know, really think of that Hashimoto's thyroiditis. That's a big one. what would this person look like if they had low thyroid hormone? Tell me some signs and symptoms.
Weight gain,
Weight gain,
brittle hair,
brittle hair, everything's kind of like slow, right? So remember that one question we just had on that, the point thing we just did? So the one thing about the heart rate, remember the heart rate was slow. Usually you have problems with constipation. Your mood is really funny. Like you're, not that you're depressed, but you can't think clearly. Like you have a hard time like functioning really well in day-to-day life because you just feel like you can't think right. I'm trying to think of some other ones that were on that thing. You guys think of anything else? Oh, the intolerance to cold, right? So this person always feels cold no matter what they do. Okay, so what's our treatment for hypothyroid?
Thyroid hormone replacement.
Yes. So it's going to be levothyroxine or Synthroid, whatever it's called. You know, there's a lot of different versions of that. But again, that is just replacement for that hormone that you don't have. So when you first get put on it, they'll put you on like a lower dose and they'll titrate you up until they get you to the right level. And so sometimes it takes quite a few weeks before you start to feel better. You're not going to have like instant relief from this. But then once it actually gets, you know, to where it needs to be, you actually feel a ton better. This person has to take that for the rest of their life. They can never go off of it. Okay, tell me about, there's a complication where this is to the extreme. Do you remember what we talked about in class? What was that called? Where all your symptoms are like really extreme. Everything's super, super slow. Remember, that's myxedema coma. So typically, you know, maybe you don't realize you're hypothyroid and that's how you find out because you go into this myxedema coma, or maybe you just got really sick and didn't treat it, you know, so you end up this way. So remember, with this, you just treat all the symptoms. So if your temperature is super low, you try to warm them up. If they have a really low heart rate, you know, you're going to put them on a cardiac monitor and watch and give them stuff for that. So you treat all the symptoms. Okay, so hyperthyroid, now we're the opposite. Now we're making too much thyroid hormone, so our metabolism is really fast. So now our T3 and T4 is too much, that's increased. So what's our TSH going to be doing?
Would it be decreased?
Yes, that is decreased. So this person can have this for a number of different reasons, right? So one of the things that we said as a cause for this, that's probably the number one cause, is what? Where you have some significant weird symptoms.
Is that Graves' disease?
Yes. So with Graves' disease, remember, you have that goiter, you have the eyeballs that are like protruding, you have that pretibial myxedema. All of those things are specific to Graves' disease. So that could be something that could cause it. And then remember, we said when you go to the doctor and your doctor like feels your thyroid right here, they're feeling for nodules, right? So that would be another reason, that toxic nodular goiter. So if you had that, that could be another cause. Now, how do we treat hyperthyroidism? There's a number of different ways. Tell me what you know.
Like supplements, maybe?
What do you mean by supplements?
I don't know. I was just a guess.
Okay.
I'm guessing. Dipshit.
What's that? I didn't hear what that, whoever said something. So remember, there's a few different things you could do for hyper. So there's medicine that you can put someone on, right? So there's two specific medicines that we mentioned that you should be knowing. So one of them is Tapazole or Methimazole, and the other one is that PTU, which I can't pronounce that one. Propylthiouracil, I think is how it's pronounced. So what these do is they work by blocking your thyroid gland's ability to make new thyroid hormone. So because you're making too much of the thyroid hormone, by giving these, it blocks that ability, so you're not making too much anymore. Does that make sense? Is anyone listening to me anymore?
Yeah.
Okay, no one's saying anything. All right, so those two meds, that would be one thing that you could do to treat this. Another thing you could do, remember we said surgery is an option, right? So typically if you have those toxic nodular goiters, typically they'll take your thyroid out for that. Now, when they do the thyroidectomy, sometimes they prefer to give you some medicine in preparation for the surgery to get the thyroid gland to shrink up a little bit more so it's easier to take out. Because sometimes, it's just really like swollen and big. So one of the things they could do is give you radioactive iodine. And remember, this is where you would have to be separated from your family. Everything that you do is like different. Like you have to have a bedside commode. You can't go to the bathroom in the normal toilet. If you wash your clothes, it has to be separate from everyone else's. If you're eating, you have to eat with plastic silverware and all that because you're basically radioactive while you're on this. And so the idea is, you take this for a certain period of time and then it helps to shrink up that thyroid. So then go to the thyroidectomy. What do you guys remember about that?
If your thyroid's removed, that's when you need to be on like supplements for the rest of your life.
Yes, which would be Synthroid. So when we do a thyroidectomy, is this person in the hospital for a long period of time?
No.
No, it's pretty much, you have the surgery one day, you go home the next. It's really quick. You have a really tiny little incision. It's on your neck here. And because our incision's here in the neck, what are we worried about after surgery? What are some possible complications?
Aspiration? Because they're breathing issues?
Well, we're worried about their airway for sure, right?
Yes.
Because we're right here in the neck, and you could have swelling and stuff, and that could cut off your airway. So that's our biggest concern right there. So because we're worried about swelling, a lot of times when they come out of surgery, you'll see them have an ice bag on their incision for a little bit to help with that swelling. What else would we be worried about after surgery?
Infection?
Well, yeah. I mean, with every surgery, we're worried about that. But we're worried about bleeding. That's another thing, right? So with bleeding, you don't want to see a ton of blood on that dressing. You only want to see maybe a scant amount, and that's it. So if that could be, a big problem there. The other thing is we want them to talk to us after the surgery because there's a problem, or if there's a problem, you could have a problem with your vocal cords because that's right there, So we're worried about that. And then there's one other thing that no one's mentioned yet that's probably the most important.
Is it low calcium?
Yes. So the low calcium is our biggest concern. So what are those two signs that we might do after surgery with this person to help check and see if they have a calcium problem?
The Trousseau sign and Chopstick sign?
Yes. Which one's which? So the chopsticks is the one on the face where you're tapping their spot on their face. The other one, the Trousseau's, is the one with the blood pressure cuff where you pump it up on their arm and you leave it pumped up for a little bit. So that's the difference between those. So remember, we're always going to be drawing blood work and stuff as well. So we're not just solely relying on those, doing those signs. You know, that's not all we're going to be doing. The other stuff, remember we said that it's really important to not be supine afterwards. We want this person to be sitting up. We want to constantly support their head and neck because we don't want to like hyperextend their neck because that could be a big problem. All right, so those are some things that are important about that. And then what's the, so remember we just talked about with hypothyroid, we talked about myxedema coma, you know, where you had all of those symptoms to the extreme. So again, with hyperthyroid, you can have symptoms to the extreme as well. And this could happen after a thyroidectomy, where all of your thyroid hormones just shoot into your bloodstream really quickly, causing this to happen. What's that called? That's thyroid storm. So with thyroid storm, it again, just like we said with myxedema coma, you basically just treat the symptoms. So now you're having symptoms that are just like ridiculously crazy. So not only is your heart rate high, but it may be like extremely high. Not only is your temperature up, but it may be really high, like 106, who knows? So everything that you have going on, you're just treating those symptoms. And then also remember, because they have too much thyroid hormone, you're going to be giving those medications IV. So like your Tapazole or your PTU, you're going to be giving that to help with this issue, because it's really important to get it then, because cripe, you have too much of this in your system now. Okay, tell me what you remember about diabetes insipidus.
It's a deficiency in ADH.
Okay, and what does our ADH hormone do for us?
It controls fluid removal rate.
Okay, good. So do we have too much or too little of it with diabetes insipidus?
Too little.
Too little, good job. Okay, so what would we look like if we had diabetes insipidus? What would our signs and symptoms be? What's the number one sign and symptom that every one of you should be saying right now?
Polyuria.
Yes. So they're peeing up a storm, right? So they're putting out like 20 liters of urine. So this person is putting out all of this dilute urine, and they're extremely thirsty, and they're going to look like they're super dehydrated. So all of your signs and symptoms would be like that. But your number one thing would be all of that urine that they're putting out. Okay, remember when we had those slides about our labs? So what would our labs look like? What would the urine be like?
Diluted.
Very dilute. So everything urine test wise, like specific gravity, urine potassium, all of these things, everything would be low, right? Very dilute. Now, what would our blood work be like?
Concentrated.
Very concentrated. So everything would be high. So that's kind of how you have to think of these things in this. What do we do for treatment for this? Isn't there a specific medication that we give for this?
Diuretics.
Not diuretics, because remember, we're dehydrated.
Okay.
Desmopressin?
Yes. So remember, desmopressin is just like a synthetic version of vasopressin. And what's vasopressin? It's just like ADH. That's what it is. So when we give this, this person's already low in ADH, so you're just giving them some ADH, but it's a synthetic version. So it's a man-made hormone that is used to help control that urination. So if you ever had a question that said, hey, how would you know that your treatment of diabetes insipidus is working? You would say, hey, they have less urine output now. That would be your number one thing. Okay, so of course, if someone's dehydrated, there's some things other interventions that we would do. So obviously we would really keep a close eye on their weight and their intake and output and all that kind of stuff. But basically they have to be on this medication for the rest of their life. Like, you cannot fix diabetes insipidus. Can you think of some things that cause this?
Maybe like liver damage or pancreas damage or something like that?
No, because think about where this is coming from. Where do we secrete our ADH from?
The hypothalamus, so like head trauma or a tumor.
Yes. So it's going to be
Perfect.
more stuff like that. All right, and then let's talk about SIADH then. So SIADH is the opposite. So we said we had not enough ADH with diabetes insipidus. So now we have too much of it. So if we have too much of it, what are we going to look like?
We'd probably have like a lot of edema, right?
Okay, yeah. You're going to have too much fluid on board. And what I mean by that is all of this fluid is going to be outside of your cells in your bloodstream. And so, yeah, you would have edema. You would probably have crackles when you listen to their lungs. They may be like really dyspneic, so they may seem really short of breath. What else? Don't you remember like jugular vein distension? What would your heart rate and your blood pressure be doing?
Wouldn't you be tachycardic?
Mm-hmm. Yeah, and your blood pressure would be high too. So those are some signs and symptoms. And then think about, okay, with diabetes insipidus, our big thing was urine, right? We had too much urine. So what would it be like here in SIADH?
Well, you wouldn't pee.
Well, it's not that you wouldn't pee, but you're just not putting out as much. It's going to be like little. So it'll be like real concentrated urine, right? So as far as our labs go, concentrated urine, dilute blood work with this one. All right, tell me some causes of this one. So again, think about where ADH is produced at.
Head trauma, TV.
Okay, so it could be, some type of damage to your hypothalamus or your pituitary gland. It could be, maybe from meningitis because you have an infection in your brain. It could be from like a stroke or some neuro condition like that. And then the one I really want you to remember is that lung cancer can cause this. Remember, that was real specific for SIADH. So because this person has too much fluid on board, what are we going to do for them?
Give them a loop diuretic.
Okay, that's one of the things. What else would we do?
Would you decrease fluids?
Yes, you're going to restrict fluids. And that's going to be one of the first things we do. So it is going to be pretty extreme, like maybe a 500 cc fluid restriction. Like, that's ridiculous, 500 cc's, right? What else could we do? So remember with diabetes insipidus, we gave like a vasopressin, a synthetic vasopressin to help with that. And that was, because we didn't have enough. So now because we have too much, we're going to give a medicine that's going to inhibit that ADH because we have too much of it. So this is that, I don't know how to say it, demiclocycline that I was trying to tell you in class before. So when you give this, it's going to help, it's going to affect that absorption of the ADH. So you're not going to have as much of it on board. And another thing that no one has said is you can give a hypertonic IV solution as well to help with this problem. All right, tell me what a pheochromocytoma is. No one has a thought? So this is a tumor, right? And where's the tumor going to be located at?
Would it be on your pituitary gland? No, your adrenal glands.
Your adrenal glands, yes. And where are the adrenal glands located at? Pretty much right on top of your kidneys, right? They're right down there. So what happens here is your adrenal glands, they deal with like your epinephrine and norepinephrine, those things. So when you have this tumor, what happens is you get these times where you're going to have a super high blood pressure and you're going to feel really sick. You're going to have like a lot of sweating, a headache that goes along with it. You could get tremors, shortness of breath, sometimes anxiety associated with it. But it's these episodes that you have in response to this tumor. And there's certain triggering episodes that you can have. So sometimes you can be triggered just by foods that you eat. So remember we said tyramine-rich foods. Also, certain medications can do this. Physical exertion, so maybe you just exercised or something. Stress, and also surgery can cause this. So pretty much what we do is we try to control the symptoms with medications, and typically they'll give some kind of like either a beta blocker or alpha adrenergic blocker. So those are going to help with your blood pressure, because that's what we're most concerned with. Because with this episode, anyone who has really high blood pressure, you can be at risk for stroke and MI and all these things, right? And kidney issues and stuff. So the thing to do for this is surgery. So typically we try to take this out completely, and we would leave a little bit of your adrenal gland if we could, so you have some functioning adrenal gland where you're not going to be without altogether. Now, the way that they diagnose this tumor is through a 24-hour urine test. And of course, they'll get imaging and stuff as well. All right, and then I didn't go over everything, but I'm going to real quick just talk about Addison's and Cushing's real fast, and then we'll do some questions. So remember, Addison's disease has to do with your cortisol level and your aldosterone level. So your hormones that are affected by this is going to be your mineralocorticoids, your glucocorticoids, and your sex hormones, right? Those three. And we said in the mineralocorticoids, that is your aldosterone. So if that's affected, it's going to be that. In the glucocorticoids, it's the cortisol. That's what's affected there. And then with the sex hormones, we're talking about estrogen and androgens. So with Addison's disease, you don't have enough of these hormones. You're deficient. So typically it's going to be your cortisol and your aldosterone that you're deficient in. So this person, and again, these hormones are produced by your adrenal glands as well. So this person is going to have some specific symptoms. So they are going to look like, they have a hyperpigmentation of their skin. So their skin is going to look like a bronze color. They are going to have fatigue, weight loss. They can have low blood pressure. They can have a low blood sugar. They can have a salt craving. And they can have nausea, vomiting, diarrhea, that type of stuff. So it's not uncommon for this person to have episodes of low blood sugar and like fainting as well, because of low blood pressure. And then their electrolytes are always messed up too. So they'll have a low sodium, a high potassium, and a low blood sugar. Okay, so, and then, not that you don't need to know this for the test, but you remember we talked about it, we said there's a primary and a secondary adrenal insufficiency. And then there's also like an extreme with this one too. There's Addisonian crisis. So this can happen as a result of severe stress, infection, trauma, cold exposure, all kinds of things like that. So again, you treat the symptoms and then you're going to give them what they're deficient in. So you would give them some hydrocortisone, probably something to fix their blood sugar, and probably something to fix their sodium problem as well. So when you're trying to diagnose this, again, some of the blood tests you would be doing, you would measure your hormone levels. So you would measure their cortisol and their sodium and their potassium and all of that, their aldosterone level. And then you might do something called an ACTH stimulation test, which that could tell you if they had this. And then the treatment for this is kind of different. So remember, we're going to replace what they're low in. So because they may be low in cortisol, we are going to give oral corticosteroids. So it's going to be hydrocortisone or prednisone. And then if they're low in aldosterone, we're going to give them fluticortisone. So that's used to treat the low aldosterone. And then this person also has to take salt additives all of the time because they're unable to retain salt naturally. So there are times where they may have to adjust what they do. So if they're having increased stress or they're having an infection at the time or something, they may have to take more so that that doesn't get too bad. All of these things that they take are lifelong. They can never go off of them. And then Cushing's then would be, again, the same hormones we just talked about, but now you have too much of them. So this person is going to look unhealthy. They are going to have like a big rounded middle. All of their arms and legs are going to be really skinny and thin. Things that I really want you to focus on for signs and symptoms would be the moon face. So they're going to have like this full looking face that's rounded like a moon. They are going to have the buffalo hump, which is that like rounded area on the middle part of their back between their shoulder blades. They are going to, again, be really big around the middle, so the weight gain. So you'll see like striations around their belly. You could see bruising on their skin. A lot of times they'll have petechiae, sometimes acne, red cheeks. And then other things just to think about. So remember I'm saying they're unhealthy looking. So because they're so big around the middle and their extremities are really tiny, just think, how does those little extremities support all of that weight. So they're going to be at risk for fractures. So anytime you have a question about this, you're going to say, okay, how can I prevent this person from fracturing? You're going to be really careful with how you move them. So like if they're in bed and you have to move them, you might use a draw sheet to move them instead of like pulling on them or doing whatever, because you can fracture them so easily. Let me think. Oh, this person is going to have type 2 diabetes. They're going to be at risk for lots of infections. They just don't really have much muscle mass or strength at all. And then some of the things we could do for treatment for Cushing's. So they could have surgery, you know, because they're making too much of this hormone. So they could do what they call a hypophysectomy. So this is removal of the pituitary gland. So you could do that if you had to. They could also do an adrenalectomy. So they could remove their adrenal glands. If the treatment kind of just depends on what's causing this. So like say they have a tumor that's causing it. Of course you would remove some of that if they had a tumor. Now, medications can be used to control excessive production of cortisol. So you could see them take ketoconazole for that. Mitotane and also metopyronone. So those are some of the medications they could give for it as well. So again, it just depends on what's causing it. So if it's something that's not so extreme like a tumor, then maybe they just give the medicines. But if it's something more serious like a cancer or a tumor, then yeah, they're going to remove it by surgery. Okay, you guys got super quiet. Are you still with me?
Yeah, it's just a lot to take in for me.
Yeah, it is a lot. All right, let me see if I can pull up what I want to pull up here. Okay, I'm just pulling up the Kahoot. Now this Kahoot's kind of long. It's 40 questions because there's a lot of stuff in here. I didn't want to not ask something, so I put 40 questions in here. Is there anyone else who wants to play? Carla, did you want to play?
I can't. I'm listening, but I'm also giving the baby a bath.
Oh, okay. All right, I'll just keep going then.
All right.
Okay, here we go. Okay, blank is a rare life-threatening condition that's a result of long-term untreated hypothyroidism. So this would be that myxedema coma we were talking about. So myxedema. Hyperthyroidism is when? Okay, good. So it's when your thyroid gland is overactive, so you have too much of those hormones. Good job. Okay, what causes a goiter?
Is it sad I know this from Tangled? Okay, good job. So iodine deficiency. Okay, which is a sign and symptom of hyperthyroidism? Okay, so it's weight loss, which we already knew, but you don't have a loss of appetite. Like you're still wanting to eat a lot. Okay, hypothyroidism results from what? Oh, geez, we had a problem here. So deficient production of, this should say TSH. They probably didn't have enough letters to put in here, by the thyroid gland. So if you don't have enough TSH, which actually that doesn't make sense. That should be the opposite. Yeah, this one was a weird one.
Yeah, I think this is just a screwed up question. So typically with hypo, you don't have enough thyroid hormone, so your TSH would be high. So this isn't right. So ignore this question. I'm sorry about that. I didn't even notice that. All right, what could be the cause of hypothyroidism? Hashimoto's thyroiditis. Good job.
Good job, Nestle.
Okay, think about Cushing's. We just got done talking about that. Think about what you would see with that. Good. This is that moon face that you would see. Okay, Cushing's disease occurs when what happens?
I have no idea.
Who cares? These are funny. So just think with these, with Addison's and Cushing's. Addison's, you don't have enough. Cushing's, you have too much. So the adrenal hormones are over-secreted. Okay, treatment of Addison's disease includes which of the following? Okay, so a lot of these aren't wrong, but like, prednisone is not wrong technically, but you're going to do more than one thing. You're not just treating it with one thing. So that's why this one's correct. So hydrocortisone and fludrocortisone you're giving. Remember, the hydrocortisone is for the cortisol problem, and the fludrocortisone is for your aldosterone issue. What's another name for Addison's disease? Okay, so this would, it has to do with your adrenal glands, right? So hypoadrenocorticism. That's what this would be, hypo, because you're not making enough. Obviously, it's not diabetes insipidus or pheochromocytoma, so it would be between these two. So you're not making enough. Okay, which of the following signs and symptoms would be seen in Addison's disease? So it's going to be dark pigmentation of the skin. Okay, lab abnormalities in Addison's disease include all of the following except so hypernatremia is something you would not see. So you're going to have a low sodium, a high potassium, and you could even see a high calcium with this as well. Okay, what is not an integument assessment finding in Cushing's, meaning like a skin finding, specifically with Cushing's? So the rash would be the thing that you probably wouldn't see. You definitely will see the striae. You'll see poor wound healing. This is that stuff with the sex hormones, where your sex hormones are messed up as well, where you see like breast development on men and like hair on women's faces and all that kind of stuff. Now, other stuff that you might see with this would be like petechiae would be another thing that you could possibly see in Cushing's. So think about those things when you're thinking about skin stuff. Most common lab values in hyperthyroidism. So it's going to be this one. So elevated T3 and T4, because those are your thyroid hormones, and then the low TSH. Okay, common findings in diabetes insipidus include what? So this SG stands for specific gravity, if you're trying to wonder what that means. Okay, you got it. So low urine specific gravity, meaning that the urine's so dilute that everything in there is going to be really low. Okay, diabetes insipidus occurs because of what? So it has to do with your antidiuretic hormone, so you're not making enough of it. Oh, you guys are getting really close here. Okay, an initial sign of diabetes insipidus is what? So this would be polydipsia. So because you're putting out so much urine, you're super thirsty because you're so dehydrated. So polydipsia. How does desmopressin work for diabetes insipidus? Okay, so it mimics vasopressin and increases fluid retention. That doesn't make sense. It should be this one. It mimics vasopressin and decreases fluid retention is what it should mean. You shouldn't have fluid retention though. Increases fluid retention. So no, this is right. So yes, it is. It just acts like ADH. You know, it acts like ADH would. So it causes you to not put out as much urine as what it should say. All right. In patients with SIADH, they will have which of the following? So it's going to be decreased serum osmolality. So if you think about it, they have too much fluid outside of their cells, so in your bloodstream. So if that's the case, then anything that would be floating around in the blood would be decreased. What treatments are appropriate for SIADH? So fluid restriction, because remember you have too much fluid outside of your cells. Okay. Which statement about pheochromocytoma is correct? So it's a catecholamine producing tumor. So remember we said it produces like your epinephrine, norepinephrine. So those are catecholamines. So a client is diagnosed with pheochromocytoma. The nurse understands that pheochromocytoma there you go. So it causes a release of excessive amounts of catecholamines. Okay, pheochromocytoma results from the production of too much of one. Which one of these do you think would cause you to have that increase in blood pressure? So it's going to be the epinephrine. Okay, a patient with diabetes type 2 has a blood glucose of 600, polydipsia, polyuria, and weakness. So you suspect what? So it's going to be the HHNS, right? So again, type 2 diabetics, blood sugar is really high. That, and the weakness, I guess, would be like a neuro symptom. Okay, signs and symptoms of hypoglycemia. Okay, cold and clammy, need some candy. All right, a potentially dangerous side effect of metformin is what? Okay, it's lactic acidosis. Which is a sign and symptom of DKA? Okay, good. The fruity breath on the odor to their breath. What causes type 1 diabetes? Okay, good. My pancreas stopped making insulin. So it's not that you have insulin, because the red one would be type 2 diabetes, right? Gestational diabetes may cause what kind of diabetes after pregnancy? Good, type 2. All right, teaching type 1 diabetics about sick day rules. What guideline applies to periods of illness? Good. So make sure you still take your insulin even if you're nauseated and vomiting. What are the complications of diabetes? All of the above. The hemoglobin A1C measures the average amount of blood sugar over the past. Okay, good. 2 months. Management of type 2 diabetes should include what? So all of the above.
what kind of insulin is this? So this is Levemir. So look at how close they are, Detamir, Levemir. So they're pretty similar. So remember that. So remember that's long-acting insulin. Which kind of insulin is Lispro? So Humalog. I would hope everyone would get this because look at the other options. They're so stupid. All right, what is insulin? What's it do? Okay, it's a protein that takes sugar into the cells from the blood. Okay, what are the symptoms of metabolic syndrome? Good. So you'll have a high blood sugar, a high blood pressure, and an increased waist circumference. Okay, metabolic syndrome is identified and treated to prevent what? So it helps to prevent an MI. So think about all of those things that are high with metabolic syndrome. So you have a high cholesterol, you have increased weight, you have a high blood sugar. You know, all of these things put you more at risk for MI. Okay, when should a diabetic delay exercising? Okay, good. So you remember, you know, when you're too high, that can actually make it go even higher. So you always should check your sugar before you exercise if you're diabetic. Okay, last one. Glycemic index is a measurement of what? Okay, so this is the effect of food on blood glucose. So basically, it'll look at a certain food and you'll compare that food to regular sugar, and you'll see like the effect of that food on what it does to your actual blood sugar. Okay, good job, guys. Okay. All right, any further questions before we get off here? So I know this is a lot to remember. It's a lot of stuff, even though there's only 2 chapters we went over. But you see, it's very easy to get things mixed up. And there's a lot of like simple things that you would think you would know, and sometimes you get mixed up on them. So make sure you give everything an equal look at, you know. So don't just be like, oh, I know diabetes, I'm not going to look at that very much, because then maybe you'll miss a lot, you know. So just make sure you're looking at everything equally. I know you guys have a test in your other class too, so just really make sure you're giving equal time to both classes so you're not messing up one class compared to the other. Okay? All right, if you have anything that you can think of that you need, just ask, okay? I'll see you guys on Thursday.
Thanks.
Thank you.
Thank you.